Attention deficit and hyperactive disorder, commonly known as ADHD. It is the most common neurodevelopmental disorder in children. The goals of this presentation are: how common is ADHD? What is the quality of life when untreated? What is the quality of life when ADHD is treated well? What are the causes of ADHD? Pathogenesis, diagnosis, and how to treat, and what is the prognosis of this condition. Before we delve into the details of ADHD, let's talk about history. There are lots of important things have happened in the last 200 years. I'd like to focus on three important areas. In 1775, first time ADHD was described in textbook. In 1798, Scottish textbook describes ADHD. The next 1950s, FDA approves methylphenidate for depression and narcolepsy. In 1960, methylphenidate is indicated for behavioral disorders in children. The last 30 years, there is lots of information about ADHD has been known to medical community. CDC describes ADHD as a serious public health problem. In the extended release, stimulants are approved for ADHD. Non-stimulants are also approved for ADHD during this time. The ADHD affects about 8.9% of children aged 3 to 17 years in the United States. Boys are more likely to be diagnosed with this condition than the girls. ADHD increases with advancing age in children. In 2 to 5 years of age, the incidence of ADHD only 2.1%. When the children are between 6 to 11 years, the incidence increased to 8.9%. In adolescent age, the incidence of ADHD is 11.9%. The incidence of ADHD in India ranges between 5 to 30% based on whether it is school-based study or community-based study. They also found there is a male predominance, and also they found it runs in families, meaning there is a high heritability. In addition, they found a strong correlation between ADHD and vehicular pollution and lead exposure. It has been seen most commonly in eldest child in the family and also associated with parental psychiatric illness, parental aggression, parental alcohol consumption, and also lack of breastfeeding. This article was published in 2022. It's based on two studies. First study was done in infants 0 to 12 months. They followed up over 10-year period the effect of air pollution in the development of ADHD. They found there is increased ADHD development in those patients who are exposed to air pollution. Another study was conducted to find out the short-term effects of PM10, which is particulate matter 10 nanometer, nitrogen dioxide, and sulfur dioxide. Those were all associated with increased hospital admission for ADHD. The conclusion, both the studies suggested long or short-term exposure to air pollution is associated with ADHD. The incidence of ADHD has decreased over the years. As the age advances, the incidence decrease. Around the age of 60, the incidence of ADHD is somewhere between 2 to 2.5%. Even though the incidence has decreased dramatically over the years, but the impairing symptoms and the functional impairment from the ADHD persist in two-thirds of the patients who were diagnosed earlier with ADHD. So, what are the core symptoms of ADHD? Inattention, hyperactivity, and impulsivity. In any given situation, sometimes ADHD present with inattention, predominantly inattention. ADHD, another group, ADHD present with predominantly hyperactivity. Most of the time, they have both the components, inattention, hyperactivity, we call ADHD combined. Based on the neurodevelopmental stage, the ADHD, the inattentive symptoms present differently in children and also in adults. The inattentive symptoms in children present as ease, distractibility, difficulty paying attention during conversation, difficulty focusing in a class, loses things often, forgetful in daily activities, impatient with others. They tend to be easily frustrated and irritable. The hyperactivity presents as the fidgety, restlessness, aggressive behavior while playing, excessive talking, interrupts others while talking or playing, sleep problems, trouble with waiting or taking turns. The symptoms of ADHD in adults are as follows: sense of underachievement, low self esteem, difficulty getting organized, chronic procrastination, trouble with follow through, tendency to speak with little insight into the timing or appropriateness, frequent search for stimulation, intolerance for boredom. This slide shows how the progression of symptoms happen in preschool children, school going children, and in adults. In preschool children, they present with hyperactivity, speech and language delay, and motor coordination problems. During school age, most of the ADHD patients are diagnosed. There will be a full expression because there are two sets. The the children were watched both at home and at school, and the psychiatric comorbidity manifests during this time. You will see school failure, peer rejection, and neurocognitive dysfunction. The presentation changes during adolescent and adult. They tend to smoke earlier, they use substance abuse, low self esteem, and have social disability. Inattention persists into adulthood, while hyperactive and impulsive symptoms wane as the age advances. ADHD affects there are 5 areas of life. One, it causes health problems and associated with other psychiatric comorbidities, causes psychological dysfunction, causes academic and occupational failure, causes social disability, and ADHD patients tend to take risky behaviors. The first, health problems and psychiatric comorbidities. ADHD patients tend to die prematurely. Their lifespan is shortened 12 to 13 years if they are untreated. They tend to have overweight, obesity, and hypertension. There is an association of delinquency, criminality, smoking, addiction, In children, you tend to see specific learning disability and executive dysfunction that persist into adulthood. And also disruptive behavior, mood, anxiety, elimination, tic, autism spectrum disorders present or associated with ADHD, those things also persist into adulthood. In children, specifically, we'll see developmental coordination disorder and speech and learning disorder in patients with ADHD more than those who are not having ADHD. As far as social disability in adult, ADHD patients tend to have more marital discord, separation and divorce, parenting problems, and legal problems, arrests, and incarcerations. ADHD in children, it persists into adulthood. Poor social skills, impaired family relationship, poor peer relationship, and rejection by peers. It starts early on and persists into adulthood if the patients are untreated. ADHD patients tend to have more suicidal ideation, suicide attempts, and suicide. They tend to do more suicide than the patients who do not have ADHD. They tend to have lower quality of life and low self-esteem. Emotional dysregulation, lack of motivation start from childhood and persist into adulthood. These patients, these children tend to have underachievement, grade repetition, special education needs, school expulsion, and dropping out. During adulthood, they have reduced occupational performance, unemployment. As a result, they tend to live in low socioeconomic status. Because of their risk taking behaviors, they tend to have unplanned pregnancies. And the children with ADHD tend to have more accidents and injuries. The adult and adolescent tend to have more traffic accidents, violation, and license suspension. Now, we will look at quality of life when they are treated well with medications. The studies have shown that medication improve many functional outcomes, reduce motor vehicle crashes, lower the risk of substance use. It leads to higher educational achievement and reduce mortality. There were other studies done shows the same thing. It lowers the level of accidental injuries, traumatic brain injury, substance abuse, cigarette smoking, bone fractures, sexually transmitted infections, depression, suicide, criminal activity, and teenage pregnancy. Another study shows discontinuing medication reduce the quality of life. So it is very imperative not only make the diagnosis and treat them aggressively and continue to treat them aggressively in order to prevent them from having all those comorbidities and other social disability and occupational and educational failure. ADHD often present with other comorbid conditions. The notables are oppositional defiant disorder, conduct disorder, anxiety, depression, neurosis, and substance use. This data is from CDC. Let me explain this slide a little bit so that it's easy to understand. The first column, it is overall incidence of comorbidities and its various comorbidities and their percentages. It is further divided into age group. This group on patient aged 3 to 5 years. This one patient aged 6 to 11 years, and this one in adolescents. One thing you see, there is about 80% of these patients with ADHD have comorbid disorders. Based on the age, the comorbid disorder changes. For example, when the patient is 3 to 5 years old, contact problems, developmental disability, and learning disorder predominates. When the age is between 6 to 11, again, comorbidity is 80%, but the contact disorder and learning disability become predominant. So during that time, they go to school and learn, so those areas will become magnified. During adolescent years, anxiety becomes the major comorbid disorder and also learning disability. There is a lot. ADHD runs in the families. The heritability is 80%. That means if there is a one patient, if you identify a patient in the family with the ADHD, there is a possibility there are other patients or having ADHD in that family, undiagnosed or diagnosed. There are lots of studies done from 71 to 2017. As you can see, vast majority, in fact, most of them shows high heritability of this disorder. Almost every study showed on the north of 60% heritability, most of them are 80%. In addition to genetics, the environment plays a significant role either in the causation of ADHD or magnifying the symptoms. Those environmental factors are as follows: hostile styles of parenting, maternal smoking, severe maternal deprivation, maternal alcohol use, low birth weight, premature birth, exposure to toxins like organophosphate pesticides, polychlorinated biphenyls, zinc, and exposure to lead. Let's talk about neurobiological pathways involved in ADHD. Several cortical regions of the brain are particularly implicated in ADHD. The notables are dorsolateral prefrontal cortex, inferior frontal cortex, and parietal cortex. The parietal cortex involved with attention and cognitive flexibility. The dorsolateral prefrontal cortex is involved with processing speed, working memory, planning, temporal foresight, selective attention, and switching. Inferior frontal cortex involved with inhibition, timing, and sustained attention. These areas showed morphologically cortical thinning, and also there is a delayed maturation in those areas observed in patients with ADHD. ADHD also involves subcortical structures. Important notables are ventral anterior cingulate cortex, dorsal anterior cingulate cortex. They are involved with affective and cognitive components of executive control. These subcortical structures, along with basal ganglia, which is putamen, nucleus accumbens, nucleus caudate nucleus, along with amygdala and cerebellum, form frontostriatal circuit. This circuit is implicated in context timing and motor control that is not developed well in patients with ADHD. Several neurotransmitter circuits are also involved in ADHD. The most notables are dopaminergic system and noradrenergic system. The dopaminergic system plays an important role in regulation of movement, mood regulation, attention, learning, and memory. Noradrenergic system plays a role in attention and arousal, signal to noise processing, mood regulation, and stress response. These neurotransmitters often be used as a target for the treatment of ADHD. Networks that mediate executive functions are also implicated in ADHD. The executive control is mediated between these regions: dorsal anterior cingulate cortex, thalamus, pons, basal ganglia, and cerebellum. These executive networks are involved in planning, goal-directed behavior, attention, inhibition, working memory, timing, cognitive flexibility. These networks are underactivated, and there is underactivated in patients with ADHD. There is also in evidence that there is a reduced functional interregional connectivity have also been seen in patients with ADHD. Neuroimaging has also implicated the reward system in ADHD, especially the orbitofrontal cortex, ventromedial prefrontal cortex, and along with ventral striatum. This reward processing network is underactivated in patients with ADHD. This is very important. The frontal, parietal, and thalamus forms the alerting network. It supports arousal and attention. This particular alerting network is also underactivated in ADHD. Finally, default mode network. The default mode network has been associated with mind wandering. This default mode network is abnormally enhanced in patients with ADHD, and also there is a reduced development. The default mode network is comprised of medial prefrontal cortex, posterior cingulate, and medial temporal lobe. They form the default mode network. Finally, we are coming into diagnosis part. As like any other disorder, ADHD needs good history taking, physical examination to rule out other medical conditions that could present like ADHD, and also observing the patient and doing standardized screening test, assist the diagnosis of ADHD and also identify comorbid disorders. In children, we use Connor screening and Vanderbilt evaluation. Connor screening, often used by psychologists, practitioners often use Vanderbilt, and I use personally Vanderbilt evaluation. The good thing about these screening tools, it identify the exact ADHD, whether it is predominantly inattentive or predominantly hyperactive or combined. It also identifies other comorbid conditions like oppositional defiant, contact disorder, and also anxiety and depression screening. In adults, they follow ADHD self-report scale developed by World Health Organization. What are the differential diagnoses? There are three groups. One, neurodevelopmental disabilities. Number two, psychiatric disorders. And third, medical conditions. Oftentimes, the neurodevelopmental disabilities and psychiatric disorders coexist with ADHD. On the other hand, medical conditions one need to look for and make sure these conditions do not present as inattention and hyperactivity. For example, sleep disorders, insomnia, can present as inattention, predominantly inattention, but sometimes hyperactivity. Epilepsy, inattention, vision impairment, hearing impairment can cause hyperactivity and inattention. Hypo can cause inattention, hypothyroid. Hyper can cause hyperactivity, so on and so forth. So it is important to make sure we are not dealing with some medical condition that present as inattention and hyperactivity. Now, the treatment portion. Two areas. One, preschoolers, children and adolescent. Another group is adult. In preschoolers, children and adolescents, the information comes from caregivers, parents, and also the teachers. Rarely you get a self-report. Okay, like only adolescents can do, but mostly caregivers and teachers. And adults predominantly self-report. Sometimes you can get the information from significant other. We use DSM-5, ICD-11 diagnosis codes to make the diagnosis of ADHD. In preschoolers, behavior therapy could be used first. If behavior therapy fails or the symptoms are severe, then medication can be used. This is according to American Academy of Pediatrics. In children, adolescents, and adults, if there are no comorbid conditions, pharmacotherapy is the first line treatment. Typically, stimulant first, then non-stimulant. Since there are 80% of the patients have comorbid disorder, just make sure what are the comorbidities. Prior to that, before you start stimulant, make sure there are no contraindications like cardiovascular disease, seizures, acute mania, psychosis. Those are a relative contraindication for stimulants. And also we need to remember stimulants can worsen depression, anxiety, tics. With a patient present with substance use, make sure substance use is treated first before you give stimulants. Autism spectrum disorder and intellectual disability may increase the sensitivity of stimulant, may require dosage adjustment. These slides talk about comorbid conditions with ADHD. If the comorbid condition is more severe than ADHD, then treat the comorbid condition. When comorbid condition is stable, then treat ADHD. If there is no comorbid conditions, make sure there are no contraindication for usage of the medication. If there is no contraindications, then use stimulants. You have amphetamines and methylphenidate to use. But these two stimulants available in short acting form, intermediate acting form, and long acting form. Short acting means the effect lasts for 2 to 4 hours. Intermediate acting means the effect lasts for 6 to 8 hours. Long acting means the effect lasts for 10 to 12 hours. I prefer in children long acting because the morning I tend to give the medication so that nobody should know about this patient is on medication because it's a taboo. The children will bully. Even the teachers will have a biased outlook on the child. So as a reason, I exclusively use long acting, except there are few kids I use long acting and short acting together. So when you consider using non-stimulant, the options are alpha-adrenergic medications. The available medications are clonidine and guanfacine, and also atomoxetine, Strattera, viloxazine, Colbrey. Once you start the medications, there are four possible outcomes. One, it works great. Then you monitor the progress. You need to see them every 3 months. Check for the heart rate, blood pressure, growth, meaning height and weight. If there is a partial response, adjust the dose. Add some non-pharmacological treatment. If there's poor or no response at optimized dose, try another medication. It's interesting. If one stimulant doesn't work, that doesn't mean all the stimulants doesn't work. Switch other stimulant and check whether it will work. Or use a non-stimulant or combination of both. When there is an unremitting adverse effect, adjust the dose. Maybe the dose is too high. Or change the medication and treat the adverse event. This slide goes further deep into the therapy. Before I dive into that one, I want to explain to you the thickness of the arrows. Thicker the arrow means more effective the treatment. Thinner the arrow, that means it is effective but minimal. As you can see, medication plays a significant role in relieving ADHD symptoms and also moderately effective in improving the quality of life, emotional dysregulation, conduct disorder, oppositional defiant disorder and aggression, and also it improves executive dysfunction. Medication plays a significant role in treating ADHD. That's a mantra. If you take one point from this lecture, number one, it's most common neurodevelopmental disorder. Number two, it has lifelong effect. Number three, medication works. Behavior interventions also improves ADHD symptoms, quality of life and function impairment, and helps emotional dysregulation, and also helps conduct disorder, opposition defiant, and aggression. The computer-based cognitive training apparently helps executive dysfunction. I do not have personal experience using computer-based models. This one, even though the effect is minimal, there are volumes of books have written the dietary treatment for ADHD. It is fed into some of the people. Medications are bad. The diet is so natural. But there are some truths to it. I need to address that. Elimination diets, especially sugar containing beverages or high sugar containing diets, can worsen the ADHD symptoms. And also, artificial color in the food items can worsen the symptoms, so it needs to be excluded. Free fatty acids, especially omega-3, improve ADHD symptoms, but takes longer time and the effect is at the best modest. So what is the current status in United States? This data from CDC. There are three groups. The group taking currently ADHD medication, group received behavioral treatment in the last 12 months, and the people who received ADHD medication, counseling, behavioral therapy in the last 12 months. As you can see, only 50% of them taking medication at any given point. That means other 50% don't even taking medication for different reasons. So does in behavior therapy, it varies from 40 to 60%. The remaining people do not take behavioral or counseling. As a result, the half of the population who are already diagnosed with ADHD do not being treated adequately. This slide kind of shows how there is the difference between the usage of medications and behavioral therapy between boys and girls. The boys are the lavender bar and the yellow bars for the girls. Here also the very same answer. Around 50 to 60% takes the medication, therapy, or combination. That means the major chunk has not been treated well, another major chunk. So now we are at the end of this presentation. So how to treat these patients? Medication alone, behavioral therapy alone, or combination, and how long to treat? As we have seen, the medication works the best. In the absence of comorbidity, medication alone will work. In presence of comorbidities, medication with therapy is needed, especially when you have aggression, intellectual disability, and learning disorder. Definitely they need behavioral therapy and other support systems in addition to medication. How long one need to treat? It needs to be treated. Since it is a chronic neurodevelopmental disorder, it needs to be treated as long as the impairment exists. We know that two-thirds of these children continue to have impaired symptoms into adulthood. So that needs to be continued into adulthood. But one need to be careful in monitoring blood pressure, cardiovascular disease, and cerebrovascular disease. Thank you for listening. Please do not hesitate to contact us if you have any questions via americanmedicine2025@gmail.com. Our contact information can be found at ksphealth.org. This presentation will be uploaded into YouTube channel. And if you have any questions or if you want more detail about ADHD or any other topic, please let us know. Appreciate all of you.